talk about the ID Liver project. I've got quite a nice, easy job. My job is to just tell you what is ID Liver, and all the other guys are going to tell you all the fun and really great and interesting work that we've been doing. So what is ID Liver? Well, we started in, well, I say 2020, but actually it's probably before that. I started with just frustration about the pathway for people with risk factors for liver disease. So being a clinical doctor, I was seeing lots and lots of referrals with people with risk factors for liver disease for whom we had to do an assessment. And what it felt like was that the people that we were assessing weren't actually the ones with the greatest risk of developing clinical end-stage liver disease. And that disparity was really obvious. The patients I was seeing as inpatients and people with end-stage liver disease were not coming from the same groups that we were seeing assessed in my clinics. So I'd have a clinic of 12 patients, and I would feel like very few of them were ever going to go on to having the end-stage diseases that we needed to address. And it really felt like the pathways just weren't good enough. Moreover, our cutoff values that we were using were validated in the Far East or in Scandinavian populations, and they weren't really validated as a trigger point for our populations and our heterogeneous population and the Greater Manchester region. And one of the things I felt quite strongly about, and then when we first built forward on the project, was actually the solutions we needed weren't lots of clever clinical studies, research, that gave us very specific answers and excluded large swathes of people with liver disease, and especially in steatotic liver disease, which I'll just talk about in a little bit. So we needed more innovation than research, and we needed to be real world. So what was the problem, right? Like, quite frankly, we diagnosed liver disease, and we still do, far, far, far too late. The vast majority of liver disease presents at the front door in A&E, coming at end-stage liver disease with liver cancer, and that is 2/3, 3/4 of liver disease presentations with clinical significant liver disease. The other end of it, people with risk factors for liver disease, well, there's just far too many of them. We need a strategy to assess, well, stratify and assess them. 30% of the Greater Manchester adult population have risk factors for liver disease, and we can't assess them all. That's just too many. That's nearly 1 million people. We cannot simply do that. The current system's too expensive. Turning up with really end-stage liver disease, 2 weeks in hospital, lots of expensive interventions. It's simply too expensive. It's too expensive for Manchester Foundation Trust. It's also too expensive for the country, because the people dying are people of working age who are being, we are failing them and we're failing the system. Many people, I mean, Nikki just mentioned it, coming to see me here at MRI, 2 buses from Cheetham Hill, a walk. They never come here before. They don't know where they are. Our system is not set up to meet the needs of those individuals, and those are the individuals that we need to be getting out to. And just too unknown. Our original work, Jenny sat in the audience, when we went out and we'd asked people about liver disease, we got responses which I was frankly surprised by, such like, liver disease isn't relevant to our group. We don't, alcohol is not a risk factor here. And you think, but steatotic liver disease, which is the majority of my work, is absolutely a risk factor, and people didn't want to talk about it. The message just simply was just wrong. So this is the reason that we need to do something. Most other chronic liver diseases have seen year on year, decade on decade improvements. Liver disease has just gone the wrong way, 450%. This is a little bit old, this data. There's another sort of nearly 10 years further, and it's still going up. It's about 450% increase if you normalize to 1970. Mortality is going up. These are working age people. Why is this the case? Well, we've seen a massive increase in what rather clunkily and clumsily is called lifestyle liver diseases, steatotic liver disease, fatty liver disease, driven by alcohol, driven by the increase in obesity and diabetes, and a combination of the two. And the combination of two is actually quite important, because when we talk about research, we often talk about people with alcohol-related liver disease or people with metabolic dysfunction associated liver disease. But actually, there's a huge chunk of people that are usually excluded from these studies who have both of those things. They drink too much, they're overweight, they're diabetic, they carry all those risk factors. And we really wanted to make sure we were addressing those groups and we were making pathways for those groups. You can see on the left that this is a Public Health England, so obviously not called that anymore, data showing actually in the Northwest and in the Greater Manchester region, we have some of the highest rates of mortality associated with liver disease. So this is really the place to be doing this work. So, what did we do? Well, we applied for funding initially to Innovate UK and secured £2.5 million in grant, alongside £2 million matched funding from our industrial partners to get going with ID Liver. And that was the first stage, and that was started in 2020. And the project expanded then with the HIA and then the ADA, which really allowed us the opportunity to use the foundation that we'd set up in the first stages of ID Liver with the Innovate UK funding and really get out into the community, really look to see if we could identify people with the highest risk, bring them into pathways and actually be proactive about that. This schematic, I won't dwell on, just shows just sort of this idea that it wasn't just a research project. We really wanted to get out into the community. We wanted to do community liver assessments. We wanted to look up, compare our standard pathways to a more proactive pathway. But we actually wanted to go right through the cycle with this, not just the data, the development, but also actually feeding all the way back in. And what we really wanted to do, and which I think we did very successfully, was we wanted to wrap that around our patients and make sure the whole project had PPIE in the center of it, really.